Hello from New York. Good afternoon, wherever you may be in Europe, and good morning to anybody watching from the United States. This is Mount Sinai Heart. Dr. Kinney, to my left, the director, myself, George Dangas, we have two of our fellows joining, the chief fellow, Dr. Ishara next to me, Dr. Farouk as well. We have a nursing staff in the back that you see led by Christy. In this particular case, we have two techs led by Chief Tech Pablo, who's trying to hide himself. Pablo, move a little bit left or right so we can see you. Excellent. And we have the IVUS faculty. Over here on the okay, please join in. Excellent as well. All right, so have a lot of excellent team compiled a very highly complex case because we're about to show you a lot of discussions, I'm sure, regarding all the different atherectomy devices that we have in the United States. You may have wherever you may be and watching this great conference. Rotational atherectomy, orbital, lithotripsy, laser, and who else what we're going to be discussing. Dr. Kinney will start by presenting this very challenging case, and many thanks for this invitation to your great course.
Thank you for the
welcome,
invitation.
George and Anu and the team. Oh, sorry, go ahead.
Yeah.
I was just going to say welcome to the whole team. We have a
Yeah.
great panel, and we're really excited to hear your case. Go ahead.
Hello, Ajay. How are you?
Good,
so
good.
myself and George Dangas, nothing to disclose regarding this case. So this is a 61-year-old patient who actually presented with a non-STEMI last month to an outside hospital. At that time, he was diagnosed with a cath to have two vessel disease. Culprit was RCA, which was calcific, subtotal to total vessel, and then he had LAD lesion also. So the risk factors, hypertension, hyperlipidemia. They tried to do the PCI there. They were not able to cross the vessel. Therefore, the patient was transferred here for complex PCI. So he was on good medical therapy. After he was transferred, we did do the PCI. After we crossed, we actually needed a laser to get through that vessel, and a single stent was placed. So today he is here as a part of complete revascularization for the LAD and diagonal, which we will show the angiogram. Question will be, that's also a calcific vessel. We are planning to do was initially, after that in between he did not have a stress test. We thought we will need a physiology to do the LAD as well as diagonal PCI. But we have patient, I'll show you the angiogram, what we have here. So EF, that is a near normal. RCA,
oh, great result.
Looks good. You can see the stent. And this is where we are with the left system.
Yeah,
so,
very cool. Wasn't there some progression you said from the previous angiogram in this case?
So last time was about 70–80% lesion, but you already see some progression. He's actually, you see good medical therapy, high dose statin. His LDL is right now less than 50, but you see the LAD has progressed with the TIMI actually 2.5 flow in the LAD. And before injecting, you can already see tram track calcium, which is angiographically severe calcium. And this is where we are with the LAD, cranial view. So it's not a true bifurcation. You can see the diagonal also progressed. It's a large size diagonal with about 70–80% lesion there.
Yeah.
And this is where we are. So we can ask the panel, how would we proceed in this case?
Yeah, would anybody still do physiology here?
Well, I think it's a great case for a couple of reasons. One is it shows you that often when there's calcium in one vessel, you're going to have calcium on the other side. The second is often in these ACS situations, we see the culprit lesion, we treat the culprit lesion, we bring the patient back, and then the vessel looks better than it did before, whereas in this case, it actually looks worse. So yeah, I agree with you, George. I wouldn't do physiology. I don't think anybody's going to dispute that from the panel. But thoughts from the panel about A, how you deal with the bifurcation, and B, the strategy you would use to deal with the calcified lesions. Maybe I'll ask you first, Margaret. Go ahead.
Yeah, sorry, George, could we see the caudal view again, just to see the proximal end? So, okay, so it looks like we've got a nice landing zone in the proximal LAD, and then it looks like there's calcium, as you said, on both sides of the artery in this view. I think what I would do is I'd wire the vessel I'd be tempted, I have to say, to try and pass an imaging catheter just to give me some more information. There's a good chance that won't cross because it looks pretty tight. And in that case, that might make your decision just to go straight to atherectomy if you can't cross with the imaging catheter. So that would probably be my plan from the outset. And as you said, it looked from the angiogram like the ostium of the diagonal is not particularly involved. But again, you'll be able to see that once you get to the imaging stage in the procedure.
Maybe a question for Anu and George is that this is a pretty large LAD and that lesion's pretty tight there proximally, but would anybody think, because this is a larger vessel, of just trying to go, if you can cross with a balloon, to go with a lithotripsy type strategy, or even taking a bigger burr? Because if you take a 1.5 burr, you may get some modification, but it might not be as much as you potentially need. So what are your thoughts on that?
That's an interesting question, especially, we have been a big atherectomy center. I like that. Since it's a large vessel, the question always comes, what is atherectomy strategy you want to use? So here, nothing wrong that proximal vessel, that we should be able to do IVL in this case rather than doing the good old previous atherectomy devices, which could be both a rotational atherectomy, or anybody who wants to consider orbital atherectomy. This is a case for orbital atherectomy also. The other thing that we could do, I like Margaret, a question that could we have passed. We also thought that imaging catheter would not go through that, but after wiring it with the rota wire, guess what? The OCT did pass on the rota wire. Confirm our angiographic finding. So then going to the next step, we can just show the OCT pictures now.
Let's look at the OCT. And Ajay, you did a very either bigger burr or lithotripsy or other techniques are all in the mix here. Let's go to our imaging faculty to present the OCT.
So okay. It's a proximal part, like concentric.
Louder, please.
Three quadrant calcium and a little bit protruding inside.
Just stop at the lesion.
So this is the tightest part. The severe calcium is a proximal LAD, like 360 calcium, and so thick calcium, I can check the thickness, like here to here, like more than 1 millimeter, and 3 quadrant. And just the proximal part is like a little bit protruding. It's like calcified nodule.
He has a microphone, I cannot hear.
And here's a interesting finding. The deep calcium and this proximal part, it looks like old rupture or organized thrombus or something. So, but through the vessel, a lot of calcium.
That's a pretty interesting picture, because you can see the calcium throughout the vessel, but at the lesion site itself, it does look like there's some rupture or healing or something beyond the calcium in the tightest area of it. But then there is clearly calcium in the lot of segments. So what were your thoughts?
It's a progression.
Yeah, exactly.
So
tell us what your thoughts are on doing.
Ajay, going back to your question that could we do IVL here? Yes, I think knowing that it is severe calcium based on imaging criteria also, 3 quadrant of calcium is there. Can we do IVL? We could do IVL. Would it pass? We are not sure in that situation, small balloon and then go in. But I think here what we have decided, we will do rotational atherectomy. We have 175 burr. Let's do that and see how the vessel behaves. And then we can make a decision that after that, do we need extra, atherectomy
or
we just do high pressure balloon, see how it behaves. If angiographically we know the vessel has fully dilated, then we can just, proceed with the stenting.
Makes sense. Azim, tell us a little bit about... Yeah, go ahead, Anu, go ahead.
For the diagonal, that's the thing. Pre-procedure, we need to plan. Should we do anything for the diagonal, or do we consider leave it alone?
Yeah, why don't we get some panel opinions regarding approach to the diagonal? Yeah. I think approach to LAD was well addressed. Would we nothing? I mean, could the stent be limited to before the diagonal, or there's a strategy to even do some atherectomy of some sort in the diagonal or not?
Can we see again the aerial cranial projection?
Yeah, it's a little hard for us to see in the cranial because of the way the screen is oriented, but looks like the origin's all right. There's a little bit of disease in the diagonal just beyond the origin, but it's not a small diagonal given how far out it extends. So Azim, what are your thoughts on this? How would you deal with
I
this?
agree. I mean, it's not a small diagonal, but it looks like, I need to see on the imaging where the diagonal comes off, but it looks like you could potentially be provisional on the diagonal and maybe even land your stent before the diagonal without actually jailing it. If that's possible based on the imaging, that's what I would try and do. Even if I needed to go across it, I'm still a huge believer in the provisional approach unless I really have to stent because of severe disease. I think you can get away with provisional in this case.
What's really nice about the OCT is two things. A, it crosses because it has a lower profile than the conventional IVUS catheter. Obviously, there are many other IVUS catheters out there that would cross potentially too. But then B, you can actually see the dots on the longitudinal view of where the branches come off. And by looking at those dots and looking at the origins, you can then determine what the origins look like, even with a drive-by view of the main vessel. So I think this is a great strategy. Anyone have any reservations about using rotational atherectomy if this happened to be thrombus or thrombotic? I don't see anybody shaking their head no.
No,
Didier?
not at all.
Yeah, go ahead.
No. I think that's the right strategy. What is the size of the guiding catheter that you're using, George? Because this is going to dictate 7 French, okay.
7 French.
So I think this is a good message because if we need to upgrade the size of the burr, we need to be prepared in advance, and using a 5 or 6 French guiding catheter may be a problem, an issue for this proximal LED.
Yeah, no, I would agree. I think if you were going to use orbital, you could use 6 French. There's no issue there. And you could potentially, if you went slowly enough, get up to 1.75 or around that, 1.7 or so, if you were doing it. So that would be another potential strategy to use. But there are many ways to do these cases. But as we all know, I mean, Mount Sinai's experience with rotational atherectomy is extensive. And this is kind of a bread and butter type of case for the team over there.
So I have
you want to
question
comment a little bit on your techniques? Because I have to tell you, in recent transmissions, I've seen people fly down the vessel. So tell us how you go through it. I know you do a great teaching job on this.
Okay, so I think we did not go through the first. Before we start, I just want to tell people how do you prepare this. This is a Rota Pro, or the good old or classical Rota where we used to have a pedal. Doesn't have everything comes here. The control is here. So you have the knob. So as soon as you reach there, first thing you do is you move the knob backward forward. So your tension between the Teflon sheath and the burr is removed. Once that is done, you tight here, and then at the Y connector, move the rota backward forward. So any tension between the rota burr and the wire is removed. And the last one, this is the Dyna, which is between 65, 70,000 RPM. On Dyna, you just tap. So even if the burr moves, it moves very slowly, so that initial jump does not happen. So this is a crucial step, so that no tension in the rotational atherectomy burr. And same thing, it went very smoothly up to the proximal LED. So once I'm there, slow pecking motion. So that's what I'm doing here. So every time I go a few millimeters backward, forward. You don't have to come back a lot because the rotational atherectomy happens only during the forward movement. Compared to orbital atherectomy, it is doing that when you're going backward as well as forward, since you have the diamond chips both in the front of the bar as well as behind.
And Ajay, you were saying that flying down the vessel, you have to avoid it not only in the beginning, that you see all these 3 steps, avoid the storage of the motion, and otherwise it may cause a proximal dissection before you even start. And then the second one is that if you push it through the lesion, you may force it through, and then it may get stuck. So you have to really go slowly back and forth, as you see, very patiently, in order to ablate your way through the lesion and avoid pushing it through the lesion, because there's no diamond chips towards the back, and the burr may get stuck. And periodically we flush the vessel in between the burr lesions, the burrings, to get rid of the debris more efficiently.
I crossed it, and now I'm just doing a polishing run.
No, I think that's the perfect demonstration of technique, and we're going to go in a second to Leipzig, but I just want to make a point that this was illustrated extremely well. And I often joke facetiously to the fellows that you got to keep your right eye on the wire, your left eye on the guide, because as you're going forward, if either of them moves back, then you know you're pushing too hard or too aggressively. And it's a really pecking motion with, with the slow, patient way of going through it so the burr doesn't get stuck. And so this was great. That's a great demonstration. Anu and George, we're going to jump to Leipzig. I'm assuming you're going to go through it, and then you'll either dilate and then talk about that when we come back, image, and then go from there. But this is a fantastic demonstration of how to do Rota.
Exactly. Thank you.
Thank
we'll
you.
proceed and
We'll proceed,
show
yeah.
back later.
Yeah, come back.
Perfect.
Yeah, hi
Hey,
Ajay.
Dimitri and Holger,
dear
how are you?
colleagues. Thank you, fine. Hi Ajay, and also dear colleagues, it's a pleasure to be part of the TIO 2020, and we also prepared a case with left main calcification and stenting. I'm here together with Dimitri Sulimov. He is the head of our cath lab here at the Heart Center Leipzig. As you can see, in contrast to New York, we are only two people here at the table. And yeah, we will show you what we want to do. So maybe I can get the slides for the case presentation. So as you can see it here, so we do a PCI of a calcified left main bifurcation. As you can see it, we have a 86-year-old male patient on our cath lab table, and he presented 2 days ago with shortness of breath and intermittent angina at rest. And he had a high sensitivity cardiac troponin T of more than 200, as you can see it here, so qualifying him as a non-STEMI. And coronary angiography was performed in the referring hospital. Next slide. We can show it to you. As you can see it here, there's a Medina 110 calcified proximal LAD, left main bifurcation stenosis, and with a lot of calcification in the LAD as well as in the left main. Next slide. You can also see that the RCA is slightly affected more distally, but we do not believe that this is relevant at this time. Next slide. And as you can see it here, this is his echo. So ejection fraction is roughly maybe 15–20%. As you can see, there's also a small thrombus in the apex, as you can see. And next slide, you can see the strategy, what we want to do. So we aim to rotablate the left main into the LAD. Then we want to do an IVUS. And we also do, our strategy is to do provisional stenting with kissing balloon. And very importantly, because this patient has impaired renal function, we aim at a very low contrast procedure. And what we can show you in the, from the live, maybe we can just switch over. So we used left snuff box radial access, as you can see it here. We have an extra backup 3.5/6 French guiding catheter in there. And then if we can move to fluoro, I can show you what Dimitri has done. So we assessed the ostium of the left coronary artery without any contrast, as you can see it here. In the next step, we also advanced the rotor wire to the LAD without using any contrast. At this step, we currently have really 0 cc of contrast. And as you can see, the rotor wire is already in place in the distal LAD. This is the current setup what we have. Maybe go, so we advance the wire more to the distal LED. And so this is where we are currently. Maybe we can switch back to the guiding catheter to life. So we prepared the rotablator. We also have the Rotaprobe, very similar to the setting in Mount Sinai in New York. And Dimitri will now do the next step. So we maybe also important, as you can see also from the fluoroscopy, so there's severe calcification of the LED and also of the left main, and that's the reason why we decided to not do an IVUS before we start. We just decided to go first line with the rotational atherectomy. This is what we do, so we just advancing. Yes, sorry?
No, Holger, I was going to ask you really quick. In terms of the EF of 15%, did you do any optimization up front or hemodynamic assessment up front prior to proceeding? It's less about the issue of support, but mainly just to see if the patient is optimized, because if you start manipulating in the left main and the EDP is 40, or if the wedge was super high, then that patient might not tolerate it as well, and then one could consider support, one consider just diuresing the patient first before proceeding this way. So I was just curious what your approach had been to that.
Just 1 second until we have less noise. So Dimitri just started with the rotablation. So we have an impeller in place. It's very close. So in case there may be a problem with respect to hemodynamic compromise, we have at least the impeller as a backup. As you know, we are not using the intra-aortic balloon pump anymore in the setting.
Yeah, no, I fully agree with that. I think my feeling is that sometimes with these folks, they're more compensated, sometimes they're less. And so what we tend to do is we'll do an upfront, either full right heart catheterization just to make sure the hemodynamics are optimized. And then if they're fine, then we certainly wouldn't use support. If they're not fine, then we would either use support like an Impella, or we would potentially even diurese the patient more before starting.
Yeah, so he was stable, so there was also, from a clinical perspective, there were no signs of decompensation, at least in the morning. And that's the reason why we decided to not go for hemodynamic support in this situation. So as you have seen, so we have already done the rotational atherectomy, and now Dimitri is advancing. It was 1.75. With
bigger burr for the location.
Yes, that's the reason why we went for the bigger burr, because of the proximality and the left main.
Can I have the?
Yeah, I mean, it's also one of the circumstances where, I personally also, this is a style, we have both rota and an orbital, but at least some preliminary data that we had generated showed perhaps less hemodynamic perturbation with orbital. So in these types of cases, I tend to favor that approach, but obviously either one would work well. Any concern, while you work, from the panel about using lithotripsy in a case like this, with the EF of 15, no hemodynamic support, and lithotripsy, are you worried about it? And if you did do it, would you change your technique at all? Joost, what do you think? I think you're on mute. Joost, go ahead. If not, we'll have either Didier or Margaret.
Again, no sound? Ajay?
Yeah, we got you.
Do you hear me?
Yep, I hear you nicely.
Yeah, so beautiful case, 86-year-old, poor LV. I think this is the beautiful case example of high-risk PCI. Yeah, so with respect to the strategy, I like the zero or low contrast concept. There's no discussion on the amount of calcium in this case. But what you could argue is that there is obviously the need for tailoring a lesion modification strategy based on what you would have seen on imaging if you would have done an IVUS up front. I think it could have helped if there's no nodular calcification, perhaps only some deeper calcifications, then the use of shockwave to me would have been very appealing, specifically with the potential risk of hemodynamic compromise with the rota and some distal embolization. So I think your comment is valid, and I would argue that IVL, if the calcium would have allowed would have been a appealing strategy as well.
And would you do the standard, 10 seconds up, or would you make it shorter than that? How would you? Any thoughts? Azim's shaking his head. He would not do 10 seconds, or you would do 10 seconds?
No, I mean, I have no issues with using IVL in this kind of case, but I do change my strategy, especially if I have no support. So if I'm going to do this case without any support, I'm going to go maybe 5 seconds, 5 impulses, deflate, make sure the patient gets flow again, because particularly these elderly patients don't tolerate long periods of ischemia. The other question I just had, I mean, in many centers, there'd be the discussion of support in this patient and using MCS. I guess the big deterrent here is the LV thrombus is the main deterrent, but I'm still, Holger said they still have it in the room. Does that mean the LV thrombus has resolved, or if the patient deteriorates, you'll put it in despite LV thrombus? I was almost hoping to hear that Holger was going to say he had ECMO in the room as standby if he needed it.
Yeah, I think that's a super important point, and you always need to know the bailout or backup strategy in case something bad happens before going into these cases. So, Holger, what are your thoughts? How are you going to deal with that?
So, yeah, that's important. So we always have ECMO available at our cath lab. This is also something we really can start within 10 minutes. As you know, we are currently doing the ECL shock trial, which is randomizing patients to ECMO versus no ECMO, and we have currently included roughly 330 patients, only 90 missing, until we have completed the trial. That's the reason why we always have a setup of ECMO in this situation. And Azim, you are correct. So this patient with the thrombus, we just have seen the thrombus just now when we prepared only 1 hour before, when we started to do this case. And that's, you are fully correct. Putting in an impeller in a patient with LV thrombus is probably not the perfect idea.
That's the understated Holger, but it has been done. In acute situations, it's just not something that's advisable for an elective case. And that's often why, at least from my perspective, in an 86-year-old gentleman, if you had to crash on ECMO, that's a big deal. So that's typically why we would do the right heart cath first to really make sure the patient's truly optimized before starting the case in case something were to happen in that way.
Maybe
but that looks like good balloon expansion.
Yes, this was exactly the balloon expansion. Maybe, Dimitri, you can comment on what kind of balloon you have chosen.
Yes, I used 3.0 balloon and dilated it with 16 atmosphere. I think the balloon is pretty good expanded, so I would proceed with stent implantation. We will take 3.0 28 stent. Yes, please. After the implantation, the next step would be a proximal optimization.
I know you did the IVUS in between. Was the IVUS showing fracture, and you were able to get distal measurements in this regard? The one thing with the stent size here is you have to make sure that when you overexpand in the left main for POT, that's going to be adequate to accommodate the diameter of the left main. So that's where the IVUS imaging can be really helpful in these types of cases.
So maybe we can show the IVUS once again, and we can comment on this. Can you just start?
Nee, du musst auf die Zahl gehen, an der Seite.
You just have to switch to German, sorry, but we will move back to
So we'll just show this IVUS quickly, and then we'll jump back to Mount Sinai. So key finding here, you want to go to the distal segment, get your diameter measurement there, then you can come back, and if you did an automated pullback, you'd be able to get a length measurement. This was manual, so you won't. But looking at the size here, this is quite a big vessel.
Yeah.
Yes, correct.
For me personally, another point is very important in the IVUS, the orifice of the circ. In this case, we have seen in IVUS that the orifice of the circ is free from any bulky lesions. So it enables us to proceed with provisional stenting.
Exactly what our initial plan or strategy was.
Yeah. And you feel that 3.0 is going to be adequate for that LAD in the distal reference?
I would like to use the 3.0 diameter for the distal vessel and optimize proximal artery if needed. We can dilate 3.0 stent.
Yeah, that's correct. Depending, which stent is it that you're using?
It's a science stent we are using, so we can easily dilate it to at least 4.5. I think this is exactly what we want to do. We have already the balloons available to do the pot afterwards.
Okay, and as long as the left main is not bigger than that, then that's a reasonable thing. Sometimes in these circumstances, I would favor taking an under-deployed 3.5,
Exactly.
you know, and then optimizing it more approximately to get the left main as big as we possibly could get. But why don't you guys go ahead and work, and then let's go over to Mount Sinai because I know they're waiting for us.
All right, see you soon.
Seen it.
We are live.
Oh, it's perfect
right, we're
time.
back.
We just
We're
position
back.
in the stand. We just position in the stand, and you can see we're verifying the position in
Go up.
the proximal. Fluoro.
Yeah.
And going up, we can show you the previous pictures right after.
What size of stent is that?
Just a very simple teaching
So these are
point
3,
that
5,
was
24.
illustrated.
Yeah.
No, nicely
Yeah, go
illustrated
ahead.
here is that typically when you're working on the proximal LED, everybody
One
works
more.
in the cranial view, but to deploy the stent and avoid hanging back in the left main, coming back to the caudal view for the deployment is a very reasonable thing to do, and something that often gets glossed over.
Yeah, we positioned it first in the usual view, the cranial, and you were going live exactly as we were verifying the ostial position. And you can see how great the ostial position is here. We're going to go up cranial now to show you the distal and the relation with the diagonal, because you missed that positioning view. That was right before. Okay, great. Ready? Let's do this. Oh, very good. Nailed the before the takeoff of the diagonal.
We took your
Excellent.
advice. We placed it just before the diag.
Excellent. Why don't we do a little bit
Now,
of
of course, the
a
diagonal
flashback?
looks.
Now it looks, yeah.
I was going to
The
say,
diagonal
now
looks,
the diagonal looks
interesting.
enormous and severe. Yeah, exactly.
Well,
But I think
what
it's
you-
better to have that problem if you
Post-dilated.
don't jail it than if you jailed it.
We can show the.
Okay, let's see what we did after we left. We did a 175 burr, and afterwards we do an OCT. Why don't we show that OCT? Let's go to our imaging faculty
But
for
this is,
that.
yeah.
OCT after rotational atherectomy 175 right now.
Okay, sure. Yeah, this is the OCT just after the 175 loaded. So this is the proximal nodule part. Like nodule is a little bit shaved, like here, like 3 o'clock. And we go to the tightest part, Puri. So this is the tightest part. Like we thought it's an organized thrombus. And after the loader, some disruption. But still there is some deep calcium, like proximal part. This is what we find.
Great, and no
And
other
this is just
problem
rota-
in the
this is
vicinity
rota
of the
and balloon?
diagonal.
No, we just did a rota.
This is just rota,
Okay.
and following the fact that he just showed us that there was a lot of deep calcium, we decided to do an adjunctive image and adjunctive ballooning with a lithotripsy, 3.5 lithotripsy. We did four inflations and four, I would say, lithotripsy courses, and then did another OCT.
Sure.
And let's show this one now.
Sure.
But
So
can I,
this is
hey
the
George, I
final
want to
OCT.
ask Anu. I want to ask Anu a
Yes.
question though. For years, you have so much experience with doing rota with NC balloons. So tell me,
Yes.
in your opinion, what you're getting additionally with the lithotripsy after the rota compared to what you did for years so well.
I wanted to explain. Go back to the OCT with the now. Like you said, we are not, we never image like this other than we do it for live case. That was an excellent question that you asked, that how would we have handled this in the past before IVL. So we would do rotational atherectomy. So how would we select a burr? Always burr size is less than 1.5 or so. So here we know the vessel size is 3.5. We would have gone 1.5 or 1.75. We took 1.75 burr. Once that is done, we will go with the NC balloon. And NC balloon always is 1-to-1 vessel size. So we would go with the 3.5, dilate it. Dilation will be 18, 20, 22 atmospheres. And at that time, if we saw that there was a dog boning and there was no dilatation of the lesion, which means there is deep calcium, which we see now with the OCT here, that the Rota did do the job, but there is deep calcium, which was not, which we know rotational atherectomy does not do anything to the deep calcium. Then we would have changed our mind at that time. Do we go with the bigger burr, which could be again 2 or 2.15 with the 7 French, we cannot go 2.15, we would have gone 2 burr, or use Wolverine or Flextome balloon at that time to take care of that particular area where the vessel did not expand. That would have been what we would do in the past or many times before the IVL happened. But now since we have IVL to take care of the deep calcium, we went and did the sound wave.
So in brief, the OCT will show us what we did. That's what we're trying to show. Imaging faculty will follow and show us the OCT after lithotripsy, and will show specifically what we gained. Show us so we can go from theory to reality. Go ahead.
Okay, so this after the IVL, so we find the dissection, like it's behind the calcified plug. Actually, the fracture is not in the calcium, like here, but already area is big. So like this is the shape after the loader, and a little bit dissection, like between, like boundary of the calcified plug and the healthy parts. It's always we see.
No, I think that's
so after the IVL.
It's a great demonstration.
Yeah, great. So you can go now to the fluoro, and we can see that we are prepared to do the OCT again. And we did a high pressure. This is the lithotripsy ballooning, first of all. And you can see what expansion we got afterwards. And you can see the OCT performed. And this is now the high pressure balloon, which is 20. And by the OCT, the distance between osteodiagonal until the ostium LAD was 27. So after this picture, we decided to go with a 24 length stent in order to stay shorter for the diagonal, the diameter 3.5. You can see here the stent, the positioning distal, as I told you before, clearing the diagonal, the positioning proximal exactly when you join, inflation. The verification of the proximal positioning, the verification of the distal positioning, and maybe we can give a little nitro and take another picture regarding the diagonal. We'll have questions down. And then we'll have some few slides to show you regarding this case.
Yeah, the one thing I'll tell you is that I'm still not certain, and I think we need to generate data on this, is that after that initial atherectomy that you did, if you had just gone up with an NC balloon and imaged, would that have been sufficient, or did the IVL make it safer by not going up as high pressure? And that's something that's an open question at this point in time. Any comments from the panel about this? A very nice step placement, really nice. Yeah, go ahead.
So I agree completely with what you're saying. There is a lack of data proving the superiority of the IVL after Rota versus a standard NC balloon. Conversely, I think this case is a beautiful illustration showing us that if you use the IVL in a area where you don't want to extend a hematoma or a dissection into this potentially important diagonal branch, so the IVL balloon only goes to 4, max 6 atmospheres, whereas the NC balloon goes to 20, 22 atmospheres. So the likelihood of rupturing the vessel and making long dissections and potentially even perforations is potentially lower. So I think in theory it makes sense to use the IVL and lower the risk of complications.
Yeah, I completely agree. I think that's why it's such an interesting question at this point, and how we've determined one strategy versus the other is something that we'll look to imaging to sort out, frankly. Similarly, you can argue in a non-STEMI circumstance, there is a contraindication to using some of these atherectomy devices, and maybe using an upfront IVL strategy would be associated with less embolization, et cetera. So a lot of open questions and excitement in the space right now.
And it's also a very expensive strategy, right, Ajay? So we do need more data.
Yeah.
One final comment.
Go ahead, Margaret.
One other comment, in Europe, drug-eluting balloon would be a good option for the diag at this point.
Yeah, I mean, it's funny, every time you're going to, have the most pain when you're here, but not having a drug-eluting balloon option, because we just don't have them approved here yet. So that issue maybe favors more towards leaving the diagonal alone and not doing anything with it, rather than stenting it and then having 2 stents of the bifurcation with all the attendant risks that could pose.
Let's go to the OCT to show the final OCT after the stent now. You can bring that in the screen. We have just a couple of minutes, and then we have to go to the slide set. Real quick.
Yeah.
So this is the
Imaging
distal
review.
edge of the stent. Yeah, looks expanded, very expanded,
Okay.
And the proximal is also well opposed.
Okay,
Yeah.
good. Can we just show the slides
Let's
quickly?
go to the
next
slides
slide.
on the background, please.
That's a fantastic OCT. Yeah, go ahead with these slides.
Yeah, so this was, I think, before completion of the case, was that we always make sure the patient is appropriate. In this case, which we know, actually it's a prox LED also, which again fits into appropriate criteria. If there's any question of complete revascularization in this kind of patients who have had prior MI, they're coming back for PCI, always try to do a functional testing. I think most of the people know this management of calcific lesion here. We used angiographic criteria for severe calcium. If not, people like to image. So based on imaging also, this patient had not the length, but had 2 other criteria, which was arc as well as the depth. So in that situation, if it is yes, you go to rotational atherectomy, orbital atherectomy. Both could have been used in this patient. You get comfortable with any one device, you could have done that. And then subsequently, you can image and follow like we did here, that you want to do IVL or no IVL. So if the same question I think with Ajay was asking is that if you do not, if your score is less, you can go either to high pressure balloon or cutting balloon and then follow the algorithm like we have. And I think what we always like to show that we have several apps that is available on cardiologyapps.com. These apps are free to be downloaded, and all the algorithm that we follow here, and also based on all the guidelines, we have it there. How to manage calcific lesion. This is a calcificate where it is the way we show it. This was non-left main vessel. Based on imaging or angiography, we can assess the calcium and subsequently say how we do this case. So that is the calcific. So here you see that we asked, yes?
There is also OCT aid.
Yeah. No, other thing is that,
keep
you know,
going,
how
keep
you
going,
do
because we have to jump back.
No, that's how
Sorry,
to do
keep
that.
going.
And other one is, if you need to learn about OCT, we have another app
Very
for
important.
OCT. More important is that I know a lot of people like to do OCT, but understanding imaging is very hard with OCT. So we have several various images that we show, and these are the other apps that are available, which could be downloaded free. Especially for bifurcate, we have 3D, where we have a lot of animation showing various steps of the various bifurcation technique. And thank you again for giving us this opportunity.
Great. So long from
Well,
New York.
fantastic
Thank you very
and
much for
educational
the invitation.
Oh, thanks,
And
George. Anu and the
congratulations
team.
on the
That
rest
was
of
a
the
fantastic
course.
demonstration.
Absolutely.
Thanks so much,
Greetings to
everybody.
Leipzig team. So long. Bye-bye.
Bye-bye. All right, let's jump back to Leipzig. That was really instructive and educational. Thanks. All right, Holger, tell us what's been going on.
Yes, we have been working in the meantime. The last 50 minutes, we nearly finalized the case, but we can show what we have done. So when we switch to fluoro, you can see this is the positioning of the long stand, which we have discussed before. It was a 3.0 28 millimeter sign stand. So this is the positioning. This is the inflation, as you can see it here in the left main, and also the proximal LED. Then we did a pot with a 4.5 non-compliant balloon. This is the positioning. As you can see it here, this is the pot with the 4.5 balloon. And the next step, hopefully it works, yes. We did a rewiring of the left circumflex trying to engage the left circumflex using the distal strut of the stand. Oops. Yes, so we had once again 2 wires in place. Then we did another inflation of the proximal LAD because our impression was that the stent was not fully expanded, still without zero contrast at this time point. And in the next step, we did a kissing balloon with a 3.5 and a 2.5 semi-compliant balloon, as you can see here. And in the next step, we did another IVUS, which we can show also in the next step.
Daniela,
can we go to the IVUS once again?
Just a quick question for you, Holger. After the kissing inflation, do you go for a pot just for the proximal portion of the stent? Because we know that this may generate some distortion of the stent frame. Is it something that you consider?
So far we haven't done it. So, but this is, as you mentioned, Didier, this is something we can consider. Maybe just coming back, when we did the kissing balloon inflation in the LA or in the left main, we had some hemodynamic compromise. Before, the patient was always with roughly 120 millimeters of mercury systolic blood pressure, and when we did this, the patient went down to 80. But he still quickly recovered after we deflated the balloons. And now you can see, going back to the IVUS, maybe Dimitri will comment on this.
Well, we are at the distal edge of the stent. I was quite happy with the distal edge. I didn't see any dissection. The stent is well opposed. The stent is well sized, in my opinion, and quite circumferentially opened. This is the ostium of the circ, and left main without significant malposition and without dissection. I'm quite happy with the IVUS result. And this is the result after final kissing. I don't see any deformation in the left main. I think we can leave it.
Didier, do you want to do another pot?
I think that there's a theoretical risk. I was to say, the theoretical risk of leaving it elliptical, but it's dealer's choice. And my sense is, especially with that IVUS, we would measure it just to be sure that the CSA was large, but it looks quite good to me. Didier, what are your thoughts? Are you okay with it, or should he go back?
I fully agree. And we have to consider the hemodynamic status of the patient. So less maneuvers seem to be the best choice for him.
So Joost has a question. Go ahead, Joost.
Yeah. I like the comment, Holger, on the fact that in this 86-year-old patient with a poor LV and a thrombus in the apex, you had a hemodynamic compromise following the kissing balloon. So my question to you, and maybe also to the rest of the panel, is do you routinely do kissing balloon in these patients? Or would you say, well, I do provisional stenting, and if there's a nice patent ostium of the circumflex, I would be happy?
Yeah, that's a great question. I personally, I think in an 86-year-old, where less is more, I think sometimes, especially if I don't have support, I probably would have just put my stent in, did a part, made sure the ostium, the circumflex looked wide open on imaging and on my final angio, and I would have stopped there, just because I don't want to run into them. But, it shows you, though, that if you're in good hands, and these are very experienced hands at Leipzig, that you can do this. You have to be very careful. I think many of us, when we do the kissing, maybe I'd have, some vasopressors ready, some phenylephrine or something ready that I can give the patient if I see a drop in the blood pressure and just get them back up. But the kiss also doesn't have to be a long kiss, right? I mean, it's literally a very quick kiss just to open the cell struts. So I would have done a very short, 5-second kiss just to open the cell struts and come out. I think they're different approaches, but I wouldn't be, in my practice, I probably would have just been, very simple crossover stenting.
One thing to comment on, though, is that because of the...
Sorry.
Yeah, go ahead, Holger.
Sorry, I just wanted to comment on the time of our final kiss, what we have done. So this was maybe roughly 10 to 15 seconds. So we really wanted to do it as short as possible. And this is what I mentioned. So the patient recovered really immediately when we deflated the balloon. So this was only a very mild compromise of the hemodynamics during the kissing balloon inflation.
Yeah, I think when the EF is normal, you can tolerate, 30-second inflations and usually nothing. When the EF is down, then that's where you have to be more selective. The one challenge in this case is because the case is a minimal contrast case, in order to ensure that that circ is wide open and fine, generally you would take a test injection. If you have an OCT, you could do the drive-by look at the circ, but it's going to be hard to know. So maybe that's a reason why, you know, wiring and ballooning is not unreasonable. We'll see what you guys do. I personally don't subscribe to zero contrast. I think that, you know, a 3 cc injection at the very end of the case is not going to hurt the patient in terms of their overall GFR, but we'll see what you want to do, Holger. We can leave us in suspense.
This is exactly what we wanted to do. 3, maybe 5 cc of contrast, just to look how the left circumflex looks like, and also if, how the LAD and left main looks like. So this is what we just do now. So Dimitri is just preparing everything.
One thing I tend to do here is I mag out. You have biplane, which is great, but I'm magging out to be sure that you get a good look at the distal vessels to make sure there's no inadvertent wire perforation that happened down there as well.
All right, so now you can see how the ostium of the left circumflex looks like. So there is some compromise. We can discuss maybe in the panel what you suggest what to do. Maybe, yeah, we can also discuss if it is slightly hazy.
Leave it alone. I think you did a great job.
Margaret,
So
what do you
the
think?
problem is you dilated with, I think, 2.5 balloon at the ostium, which is, I think, clearly on the side for the ostium of the circ, so that should be fine. But you have the IVUS on the table, you dilated with the 2.5. You could argue that if you have the IVUS on the table, you have a look. If it's not massively dissected, no huge hematomas, and the MLA is, let's say, at 3.8 or whatsoever, or even higher, then, yeah, I think the likelihood of future complications would be low.
Fully agree. Shall we go for IVUS? Will you try?
We can try.
The question is if we get it through, but we can try because we opened the cell with a 2.5.
And it's so just a couple of comments. So I also, in this situation, wouldn't have routinely kissed either. I think now that you've kissed, you hopefully will be able to track the IVUS. The other thing that I do is if I'm going to kiss, I'll take a bigger balloon and go to low pressure, so that I get a bigger, like, rather than disrupt the intima aggressively, but I'll actually push the plaque back more effectively. So I would have gone with a bigger balloon in the side branch, but gone to very low pressure with it. Just as a different take on how to handle that. And one other thing is, I'm not sure how much of the stent was back in the left main to be able to, if this had been a 2-stent procedure, importantly, if you were going to pot at the end, you need to have left enough stent back in the left main, be able to do that without compromising the carina. So just as an educational point in general.
Yeah, you definitely have to factor that into your length determination, how much you can get proximal to the bifurcation to be able to do an effective pot. So let's see if the IVUS crosses. You know, once again, I think the availability of different IVUS catheters is very useful. In this case, it seems to have crossed, no issue, but there are lower profile catheters, even from Philips and other companies too, that for this type of case, this wouldn't really be any issue. So let's see what the pullback looks like.
Yeah, so we were able to cross with the IVUS, as you can see, and we now do the manual pullback.
There is some friction.
Yeah, the jump, it jumped a little bit there.
Yeah.
Yeah.
Well, it's not a surprise. We have some plaque, some lesion in the orifice of the circ. You can stop it.
I wonder,
at first glance, I haven't seen any dissection.
Me too.
How many people would, if they wanted to treat the circ, would do an IFR rather than the IVUS? Because, like Dimitri said, it's no surprise there's plaque there. We know there's plaque there. This is an 86-year-old where we want to revascularize what is the clinically important lesion for an 86-year-old. Wouldn't maybe physiology be better? Because I think most of us, or at least me, I'm trying not to stent that circ. So I want just enough information to make me feel comfortable to leave it alone.
No, it's a good point, Nazim. The only challenge I have with the physiologic assessment in these cases is what I really care about is not the long-term prognostic significance. It's just that you don't want the circ to go down. And if it was a dissection or something like that, if the IFR is okay right now, it might not be okay in 30 minutes. So for me, I think the imaging, if you have a good catheter, usually HD type of IVUS situation, you see nothing major, no hematoma or anything like that, then that's more reassuring than a negative IFR at this point. But I fully agree. I think you're trying to do everything you can not to stent this. But I think, Dimitri, you're probably satisfied. Even though the IVUS was kind of suboptimal, I'm assuming you're okay with this, right?
Yes.
I'm very happy, yes.
Exactly. So we have no dissection, so we still have slight stenosis up there, but we do not believe that this is relevant for the patient. And at least we are not afraid that the left circumflex will close in the next 15 or 30 minutes. So we would be happy and we would stop at this time, at this point. As you can see, maybe if you have a look on the contrast, so altogether we have done this with 6 cc of contrast, the overall procedure, including rotational atherectomy, stenting, pot, and kissing balloon inflation. So altogether 6 cc of contrast dye.
This is a fantastic case, great demonstration. Actually, both cases from the session were awesome. So thank you so much, Dimitri and Holger, and we'll see you soon.
See you soon.
Bye.
Thank you very much.
Thank you.
All right, well, with that, I think we'll conclude this morning session. Awesome didactics to start off with case discussions as well as then live cases, both from Mount Sinai and Leipzig. Just want to thank our panel again, Azim Latib, Joost Damon, Didier Cheche, and Margaret McEntegart. Stay tuned for a session. There's actually a commissural alignment session that will happen soon, as well as 2 other breakouts. We'll then rejoin after those sessions for afternoon sessions on CTO with live cases as well as some didactics. So with that, I just want to thank everybody once again. It's been a great morning.
Bye.
Bye, everybody.